Welcome to the latest MS Hear from the Experts webinar. The series is helping people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate their MS journey with more knowledge and confidence. Our intention is to help learn more about this disease, treatments, research, wellness strategies, our programs, and much more. I am Marielle Dekel. I am a person living with MS, diagnosed in 2012. I have happily joined the MS Canada team as a program delivery staff member, but you'll find me enthusiastically involved in many MS Canada events and activities throughout the year. I am truly honored to be here today as your moderator for today's broadcast. Welcome to both audiences, including those joining the broadcast on Facebook Live. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. Your microphones have been muted and will remain muted for the entirety of the broadcast. If you have a question, please type it into the chat box and we will try to get to as many questions as possible following the formal presentation. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. This session is being recorded and will be available soon on our website in English under Archive Webinars and on our YouTube channel. A Facebook Live recording will be available as well. Also, please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but instead provides information and referral to assist individuals in making their own health and wellness decisions. The views and opinions expressed in this presentation are those of the speaker and may not necessarily reflect the views or positions of MS Canada. MS Canada would like to start the session by acknowledging that we are on the unceded and ancestral territory of First Nations, Inuit, and Métis people across Canada. These nations have cared for this land from the ocean to the mountain peaks for thousands of years and continue to do so today. We thank them for their continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land we all call home. Formerly called the Multiple Sclerosis Society of Canada, we've changed our name to simply MS Canada. We've got a new name and a new look, but we are still committed to keeping people affected by MS at the heart of everything we do. Since 1948, we at MS Canada have been proud to be a part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we have helped fund research, provide information and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap to our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Today's broadcast is an opportunity to learn more about 4 diseases that have similar neurological symptoms to MS and may be referred to as MS-allied conditions. Because these diseases are considered rare, those diagnosed with one may not have access to the organization for support. MS Canada provides support and services to individuals with allied conditions, including NMOSD, transverse myelitis, ADEM, and MOGAD. Today's expert will share general information about these conditions, plus highlight some of their research and treatments. Dr. Dalia Rotstein is a neurologist at St. Michael's Hospital and an assistant professor for the Department of Medicine in Neurology at the University of Toronto. Her research is focused on the epidemiology of MS and neuromyelitis optica, NMO, in particular, the role of ethnicity, gender, and vitamin D in disease risk and disease course. Dr. Rotstein, welcome. We're looking forward to your presentation.
Thanks so much, Marielle, and thanks very much to MS Canada for hosting this session. And thanks to all of you for joining us tonight to learn more about these conditions. So the title of my talk is Understanding Allied Conditions, NMOSD, MOGAD, ADEM, and transverse myelitis. I know it's a bit of alphabet soup, but don't worry, we're going to walk you through all of these different acronyms and what they stand for. So I just wanted to start us off with some words from people who are living with these conditions. So these are very, serious conditions. They're rare diseases, as Marielle highlighted, and often people can feel quite isolated. It takes tremendous bravery and resilience to face these different diseases. Some of you may have these diagnoses or know other people affected. It's also very important to have people you can draw upon for support and also to talk to about your different symptoms. So to start us off with some words from patients, I think this is very telling. So this picture with the tree was taken from a brochure produced by the Guthrie-Jackson Foundation, which is a patient foundation dedicated to neuromyelitis optica, which is also known as NMO or NMOSD. You may have NMO, but NMO does not have you. And then we have some words that were shared from people living with MOG antibody disease or MOGAD. And this is a quote from the patient brochure from the MOG Project Patient Foundation. You may not feel okay today. That's okay. Heal at your own pace, in your own ways, and at your own time. So, this is a disease these diseases have many different manifestations. And I just wanted to highlight for you some words from people living with these conditions. I think at the end of the day, your experiences are the most important. But I'm going to give a bit of background on the medical aspects of these conditions because I think knowledge is power. And by giving you the tools to recognize different aspects of these diseases, hopefully it will also help you improve your quality of life or the lives of loved ones who are affected. So we're going to start off by talking about what exactly are these different allied demyelinating conditions and how do we distinguish the different diseases from each other as well as from multiple sclerosis, which is the most common demyelinating disease in Canada. Across these different diseases, we have the concept of an attack. And I'll define for you exactly what an attack is and how you can recognize it. We'll then turn to evaluation and management of attacks. We'll move on to talk about each condition individually. And the four conditions that we're going to talk about are NMOSD, MOGAD, ADEM, and transverse myelitis. And lastly, we'll speak about resources that you can access for further education and also for finding other sources of support. So what are these allied demyelinating diseases? Well, they're all autoimmune diseases of the central nervous system. An autoimmune disease occurs when the immune system attacks the body itself instead of infections or intruders. So we all have immune systems, and their intent is to help protect us against infections. But sometimes the immune system goes awry or goes into overdrive, and instead of acting how it's supposed to, it attacks certain tissues in the body. And in the case of these demyelinating diseases, the immune system is attacking the nervous system tissue. And specifically, it's attacking the white matter of the optic nerve, the brain, and/or the spinal cord. So the optic nerve is essentially this cable which connects the eye to the brain and provides visual information. I think we're all familiar with what the brain is. And then the spinal cord, carries the nerves from the brain to the rest of the body. So the nerves are carried to the different limbs as well as to your trunk and to your bladder and bowel. These diseases can be multiphasic, which means they can involve multiple attacks spread out over time, or some of these diseases just involve a single attack and are considered monophasic. And I'm going to outline on the next slide which is which. Importantly, these diseases are not multiple sclerosis. So multiple sclerosis, as I said, is the most common demyelinating disease. It affects about 1 in 400 people in Canada. These diseases are different. They have a different underlying pathology and often different approaches to treatment. And they're much more rare. So they affect anywhere from 1 in 100,000 Canadians to 1 in a million Canadians. The monophasic diseases involve just a single attack. Now, there are some rare exceptions, but these are general rules. So transverse myelitis is usually a disease with a single attack on the spinal cord. The myelitis part means spinal cord. So essentially, it's an inflammatory attack on the spinal cord, and I'll tell you more about that later. ADEM is also a monophasic disease with a single attack. It stands for acute disseminated encephalomyelitis. MOGAD or MOG antibody disease can be either monophasic or multiphasic. So about 50% have a single attack and about 50% have multiple attacks. And that's why you see MOGAD under both columns. Neuromyelitis optica or NMOSD is a disease that involves multiple attacks. And it's very important with that condition that patients be placed on a long-term therapy to prevent future attacks, which can be very disabling. So occasionally, because we can diagnose NMOSD today after a single attack, we'll see people with a single attack simply because they've remained on a therapy long-term that has prevented future attacks. But if this condition is not treated, virtually everybody will have those multiple attacks. So how do we distinguish these diseases from each other and from multiple sclerosis? So this is a very important part of the workup when a person first presents, because there is overlap between the attack types that I just mentioned and MS, which is much more common. So the first step is to perform blood tests for different antibodies. So we're lucky today that in the last 20 years, certain diagnostic antibodies were identified in the blood that allows us to distinguish NMOSD as well as MOGAD or MOG antibody disease from MS. So both of these diseases are associated with certain specific antibodies in the blood. In NMOSD, we have the NMO antibody, also known as the aquaporin 4 antibody, which is positive. And the figure here shows you the antibodies in NMOSD. So those little upside down Ys represent antibodies. And essentially the antibody in this disease is against a component of the water channel of astrocytes. Astrocytes are supportive cells in the central nervous system. But these antibodies are manufactured in the general blood system, and then the antibodies cross the blood-brain barrier to enter the central nervous system, where the antibodies bind to the astrocytes, and then the disease is triggered. So we only need to perform a simple blood test in order to diagnose this disease. We also have an antibody associated with MOG antibody disease, called the MOG antibody. This antibody is sometimes also positive in ADEM because ADEM can be an attack type associated with MOG antibody disease. So whenever ADEM presents, it's also important to perform this blood test. But I want you to recognize that there is no blood test or antibody test for multiple sclerosis. So we can use these tests to identify the other diseases, but we don't have a blood test for MS. Another important part of the workup is the clinical history. So these are the questions that the doctor asks when a patient comes in with suggestive symptoms of an attack. So it's very important to know what neurologic symptoms are involved, because knowing which symptoms are involved can help us identify the location of the nervous system affected. It's also very important to ask if there's any history of previous neurologic episodes or attacks. So as I mentioned before, many of these diseases just involve a single attack. So a history of previous episodes might point away from these diseases and towards a disease like multiple sclerosis. We also ask, what is the recovery like? Because we know that certain of these conditions, especially NMOSD, are associated with more severe attacks with less recovery compared to MS. So the extent of the recovery also helps us distinguish the different conditions. So moving on, another important part of the workup is the MRI. So the MRI gives us this incredible window into the body to see which locations of the nervous system are actually affected. So we can see which parts, of the brain or spinal cord or the optic nerve are affected. And we know that the length of the lesion is another characteristic that helps us distinguish these diseases from MS. So in MS, we usually see very short lesions, but in NMOSD and MOGAD, for example, the lesions are usually much longer. So that's another feature we can use to help have confidence that we're working towards the correct diagnosis. We can also look at the gadolinium enhancement pattern. So enhancement basically means that when dye is given for the MRI, the dye is taken up. And this is a sign that the lesions are new within the last month. It's a sign that there is breakdown of the blood-brain barrier. When we see all of the lesions enhance at the same time, we know that all of the disease is new. So for example, in ADEM, we often see many lesions, but they all enhance, meaning they're all new, they're all confined to the current episode. In multiple sclerosis, we often see many lesions, but only one or maybe two enhance. And that's a sign that many of the lesions are actually older. So the disease process has been spread out in time. And that also helps with making the correct diagnosis. And then the last test we use that really helps distinguish these diseases from MS is spinal fluid testing. So for MS, there's a test called oligoclonal banding, which is usually positive, but this test is usually negative in NMOSD, MOGAD, and transverse myelitis, although there are exceptions. And essentially, as the figure shows you there, for the oligoclonal bands test, we compare the level of proteins or bands in the spinal fluid compared to the general circulation or plasma. And at the bottom of the slide there, you can see that under normal conditions, you don't see any bands at the bottom. But the abnormal condition, which is the presence of the bands, or a positive test for MS, you do see several bands at the bottom of the gel. So this test also helps us distinguish the different conditions. And this slide here is just to illustrate some of the differences we see on the MRI and optic neuritis. Now I know this is quite complex, for people who don't have a background. You can look at the white arrow signs, which help. But the top panel is MOG antibody disease, the middle is NMOSD, and the bottom panel is multiple sclerosis. If you look at the white arrows, which are pointing to the optic nerves, you can see that the lesions or the bright signal is quite long in MOG antibody disease and in NMOSD, compared to multiple sclerosis, which is the bottom, when you see some bright signal but is over a much shorter segment. And that characteristic can also help us distinguish the disease. It also is very rare in multiple sclerosis to get optic neuritis in both eyes at the same time, which can translate into blindness in terms of clinical symptoms. Whereas in MOG antibody disease and NMOSD, we can see both optic nerves affected simultaneously. So what is an attack and how can you recognize it? Well, first I wanted to clarify that the word attack the word relapse can be used instead of attack, and many neurologists do this, but the terms are essentially interchangeable. And basically an attack refers to new neurologic symptoms that develop over hours to days and persist for at least 24 hours. So if you just have new symptoms for a few minutes at a time, that would not be considered an attack. Another important caveat is that an attack should be in the absence of fever, infection, or other non-neurologic illness. When you have another illness going on, it can bring out underlying neurologic symptoms because the brain suddenly can't compensate as well as it would normally for your previous deficit. But typically, if the symptoms are increased because of a non-neurologic illness, they should improve as soon as the other illness is treated. And this condition is known as a pseudo-attack or pseudo-relapse. But moving back to real attacks, symptoms can sometimes be the same as during a past attack if the same location is affected again, but they should be worse than they were before. It can be difficult in some cases to distinguish a new attack from fluctuation in old symptoms. If you are worried about a new attack, leave it in the expert's hands and call your neurologist or go into the emergency department. The more quickly you act on the symptoms of an attack and get appropriate treatment, often the better the outcome. So I would not sit on new symptoms for days straight. Essentially, if you have new symptoms, you can wait a few hours to see if they persist. But if they are persisting, I would get in touch with an expert right away. So I wanted to go over some of the different attack symptoms by location. So the 3 key locations that we mentioned can be affected are the optic nerve, and if you have inflammation in the optic nerve, it's known as optic neuritis. The spinal cord, a spinal cord attack is called transverse myelitis, and the brain. So with the optic neuritis, patients often experience blurry vision. The blurry vision is severe and it's in both eyes, and patients may have blindness. It's common to get eye pain with an attack, and also people often experience loss of their color vision. Sometimes people may experience visual field cuts as well, so just a segment of the visual field is affected or blacked out. With transverse myelitis or attacks on the spinal cord, people often experience weakness, difficulty walking, sensory loss, bladder, bowel, and sexual dysfunction. They can experience severe pain, as well as problems with balance. When the brain is affected, we can get many different types of symptoms. People won't necessarily have all of these symptoms. They often have just a few. But just to review possible symptoms, they may have cognitive or behavioral change. They may have problems with balance or coordination. They may experience dizziness or vertigo, like the room spinning. There's a specific attack type associated with NMOSD where people can get severe nausea, vomiting, or hiccups that doesn't respond well to medication. And it's actually coming from the brain, not from the intestines or the stomach. People may experience double vision, slurred speech. In some cases, people may experience decreased level of consciousness or even coma. And weakness and sensory loss are also possible. When it comes to evaluation of an attack, it's very important that a qualified doctor take the history and perform a physical examination. The doctor then formulates an idea of what part of the nervous system may be affected, and they're going to order investigations to figure out the nature of the problem and the cause. So as we said before, MRI is important, blood tests for different antibodies, spinal fluid testing, and the spinal fluid is obtained by doing a spinal tap, which is also known as a lumbar puncture. And then if an inflammatory cause is suspected, often patients are treated with steroids, and the response to steroids can also inform our idea of the cause, because with these different autoimmune diseases, we suspect that the patient will make some kind of response or have improvement with the steroid treatment. So management of an attack, again, we want to make sure that evaluation happens by a qualified professional as quickly as possible. If the symptoms are severe, the person affected should be admitted to hospital. All of the investigations are completed. And then if NMOSD, MOGAD, ADEM, or transverse myelitis is suspected, the first treatment is usually high-dose steroids. Some people will just make a partial response or even minimal response to the steroids, and then we usually move on to plasma exchange. And this figure here highlights plasma exchange. In basic terms, the idea is, and it's actually a pretty cool machine, that a catheter is inserted, so this tube, and through the tube, blood flows out of the patient's body. It goes through this machine where the antibodies are removed, and then the blood is circulated back into the patient's body. So it's a very, interesting machine. The plasma exchange is only available at certain centers in Canada, so that can be a little bit of a limiting factor. And if you do have any of these conditions and you get treated for an attack and you're not making a good recovery, you should ask your doctor about getting plasma exchange or getting transferred to a center where plasma exchange is available. Steroid pills or prednisone are also often used for several months after the attack to prevent worsening of the attack or another attack, which sometimes can occur in quick succession. And then different supportive services are very important. So physiotherapy and occupational therapy to help people improve from the new disability and also get used to functioning in their home environment. And stay in rehab may be needed as well. So we're going to move on now to talk about the individual conditions. First, we have NMOSD or NMO. NMOSD stands for neuromyelitis optica spectrum disorder, and NMO is neuromyelitis optica. For many years, the disease was just known as NMO, and then in 2015, it was renamed NMOSD to acknowledge that there is a broader expression of different clinical symptoms associated with this disease than was previously realized. So in the old days, it was thought that NMO might only involve optic neuritis and spinal cord or transverse myelitis attacks. But today we recognize that brain attacks are possible as well. NMOSD affects about 1 to 3 in 100,000 Canadians. It disproportionately affects women, so about 8 women are affected for every male with this condition. And it also disproportionately affects Black and East Asian people in Canada. It is a lifelong chronic disease, and attacks are often severe and associated with poor recovery. So these pie charts here just show you kind of the chance of attacks over time. So at 1 year, the risk of recurrence is about 50%. By 3 years, it's 75%. And by 5 years, 90%. But I would add that that is without appropriate therapy. So we have highly effective therapies for NMOSD today, and we can often lower the chance of an attack to close to 0, which really has been a tremendous achievement over the last 10 years. So I conducted some research here in Canada looking at the frequency of different attack types as a presenting attack. This was some work we did using a Canada-wide cohort in the Canoptic study, but it hasn't been published yet. Anyway, we found that the most common presenting attack type was transverse myelitis or a spinal cord attack. So those are attacks that present with weakness, walking impairments, sensory loss, and/or bladder bowel dysfunction. The second most common presenting type of attack was optic neuritis. In about 25% of cases, it was vision loss in one eye, but in about 6%, patients had vision loss in both eyes or even blindness where that was severe. And then a lower share presented with brain attacks. In 10%, this was the area postrema syndrome, which I mentioned before, where people can have nausea, vomiting, and hiccups. So because there are other illnesses that can cause similar symptoms like gastroenteritis, sometimes that attack type gets missed and the diagnosis is delayed as a result. And then more rarely, there are other types of brain attacks, like a brainstem attack, where people can experience vertigo, incoordination, or double vision. The diagnostic criteria for NMOSD were most recently revised in 2015, but they're actually undergoing revision right now, so we expect another version will be published in 2025. Most people with NMOSD have the positive blood test for the aquaporin 4 antibody. In that case, where the blood test is positive, the disease can be diagnosed after a single attack. But if the blood test is negative, there are some people who still have what we call the clinical phenotype of NMOSD, and they often respond to similar treatments. But in that case, you have to demonstrate at least 2 different core clinical locations affected, including one of the classic attacks, which is the optic neuritis, the spinal cord involvement or myelitis, and the area postrema syndrome with the nausea, vomiting, or hiccups. And there are also certain MRI requirements if the blood test is negative. So I just wanted to quickly show you some images from people with NMOSD. Of course, this is kind of advanced, but just to give you a sense that different areas of the brain can be affected. And then with the spinal cord attacks, we see these very long lesions. So if you're basically looking at that gray column going down, and usually that column is gray through and through, so the white signal in the middle of the column is abnormal. In multiple sclerosis, when the spinal cord is affected, we just see very short lesions or very short segments of bright signal, but in NMOSD, we see these very long areas of bright signal. We do have therapies for NMOSD. So we have certain therapies which are off-label, which means that they were never formally studied in a clinical trial. And that's because of the rarity of this disease. And for a long time, there wasn't funding for research. So these include steroids, azathioprine, which is a broad immunosuppressive drug. It's a pill. Mycophenolate, or the brand name is Cellcept, which is another pill. And rituximab, which is an infusion which is given once every 6 months. We're very fortunate, though, that there were a number of different clinical trials that were done within the last 10 years, and then the results were published in 2019 and 2020. And these drugs have all since been approved by Health Canada. So we have 4 new drugs that were very successful at preventing attacks in NMOSD. Eculizumab, which is an infusion which is given every 2 weeks. Inebilizumab, which is given by infusion every 6 months. Ravulizumab, which is an infusion which is given every 8 weeks, and satralizumab, which is a monthly injection. So these drugs are quite expensive, so they're not widely available for everybody with NMOSD, but for some people who fail their first drug and have a breakthrough attack, then we can gain access to these drugs, and the funding for other drugs is still being decided. So we're going to move on now to MOGAD, or MOG antibody disease. This disease is estimated to affect about 1 in 100,000. But the blood test, or the MOG antibody, was only recently identified and associated with this disease in around 2015. So we're still learning more about this disease and identifying new cases. We have some patients who were originally diagnosed with MS, and the diagnosis was since revised to MOG antibody disease. So the frequency of 1 in 100,000 may actually be an underestimate. In order to receive this diagnosis, you need to have a positive blood test for the MOG antibody and at least 1 typical attack. Onset is actually more frequent in childhood and adolescence before age 18, but it can occur at any age. And we have some patients who present with MOG antibody disease even into their 60s and 70s. About 50% or half have a single attack, and about 50% go on to have multiple attacks. Preventative long-term therapies are only usually recommended after the second attack, because we do know that, a significant share of people will never have another attack. So we have different attack types that can be associated with MOGAD. We have the optic neuritis, which can cause vision loss in one or both eyes. We have the myelitis, or spinal cord attack, which can be associated with weakness, walking impairment, sensory loss, or bladder or bowel dysfunction. There's the ADEM attack, which is a diffuse brain attack, which can often cause changes in thinking or behavior, altered level of consciousness, weakness, sensory loss, or seizures. And this attack type is more frequent in children and more likely to be an isolated attack. So not to be followed by other attacks. The optic neuritis attack type has the highest risk of being associated with later attacks. We also have cerebral or brain attacks, which can be associated with weakness, sensory impairment, or cognitive changes. There are brainstem or cerebellar attacks, which means the lower part of the brain is affected, and these can be associated with vertigo, nausea, impaired coordination, double vision, slurred speech, weakness, or sensory impairment. And the last type of attack is quite rare, but distinctive. So what's called cerebral cortical encephalitis, often with seizures. In this type of attack, the gray matter of the brain is affected as well as the white matter. Patients can have fever, altered level of consciousness, seizures, problems with speech, weakness, or sensory impairment. And I just wanted to show you some MRI images of what the lesions can look like in MOG antibody disease, so they can affect different parts of the brain. They're often quite large and fluffy. And another distinctive aspect is they can affect both the gray and white matter, whereas the other diseases we talked about more often affect the white matter only. And this is an image from the last type of attack we talked about, the cerebral cortical encephalitis. So the cortex is right on the surface of the brain. So the arrows here in panel A1 show you that the surface of the brain in that area is brighter than on the other side. And then we can also see that the lining of the brain is taking up the dye, which means that the lining of the brain is also inflamed. So we did not have formal diagnostic criteria for MOGAD for some time, but in 2023, the first international diagnostic criteria were published. I know this is a busy slide, but it's just to show you that we now have diagnostic criteria for MOGAD. One challenge in MOGAD diagnosis is interpreting MOG antibody testing. There's this concept of low or high titers. So the antibody test can be quantified by titers, which basically tells us a level of positivity. And there have been reports that some of the low positive titers or low antibody levels can actually represent false positives. And sometimes low positive levels are seen in multiple sclerosis and other causes like vitamin B12 deficiency, even in healthy people. We also know that titers are often higher at the time of an attack, so it's better to send this blood test right at the time of an attack. So some people with MOG antibody disease get their blood test done a few months later, and then they have a low titer simply because the disease isn't active. So that's another complication. And some people who initially have positive blood tests can become negative over time. It does mean they have a lower risk of recurrence, but it doesn't mean that the risk goes down to 0. And over in this mini table here, you can just see what we call positive predictive value of MOG antibody testing, which means the chance that a positive test is really associated with the disease in the real world. So you can see at the very high antibody levels, or 1 to 1,000 titers, there's a 100% correlation. But at the low levels, which are titers of 1 to 20 to 1 to 40, the correlation is only 51%. So that is a challenge we encounter in clinical practice in terms of our confidence in the diagnosis. Treatment of MOGAD is often started after the second attack, as I mentioned before. We have a number of off-label therapies because we haven't had a published clinical trial yet in this space. We use some of the same drugs we use in NMOSD, including azathioprine, which is a daily pill, mycophenolate, which is a daily pill, rituximab, which is an infusion, which is given every 6 months, monthly IVIG treatment, which is a monthly infusion, and steroids, which is usually the prednisone pill. There are a couple of clinical trials, though, looking at novel drugs. So these are currently underway. So we're hoping in the future we will have treatments available which have been proven by clinical trials. And the clinical trials that are going on right now are investigating a drug called satralizumab and another drug with a very long name, rozanoliximab. I don't think I pronounced that right, but it's known as Rosie for short. So just briefly comparing diseases in terms of clinical features, this is a bit of a summary. As we mentioned, MS is the most common disease in Canada, 1 in 400 for NMOSD and MOGAD. The frequencies are estimated at around 1 in 100,000. These diseases are all slightly more common in women, but much more common for NMOSD. So the female to male ratio is 9 to 1 for NMOSD. For MOGAD and MS, it's relatively more similar, so around 2 to 1, maybe a little bit higher in MS, 2 to 3 to 1. For NMOSD, almost all patients have a relapsing course, which means multiple attacks, but for MOGAD, it's only about 50%. For NMOSD, we often see poor recovery from attacks with residual disability. For both MOGAD and MS, the recovery from attacks is usually good. So we're going to move on now to talk about ADEM. So ADEM stands for acute disseminated encephalomyelitis. It's a disease that may be triggered by infection in many cases or less commonly vaccination. It's much more common in children and adolescents compared to adults, and we see about 1 new case for every 200,000 people each year. Some of the cases of ADEM are associated with the MOG antibody, and as we said before, then it would be consistent with an ADEM attack with a concurrent diagnosis of MOG antibody disease, or MOGAD. Associated symptoms include initial symptoms such as fever, headache, and vomiting, and then an evolution over time to include neurologic symptoms such as changes in thinking or behavior, altered level of consciousness, weakness, sensory loss, incoordination, or seizures. In some cases, the optic nerves are also affected with vision loss, and the spinal cord may also be involved in some cases. And the symptoms usually peak within days to up to 4 weeks, but it can take months to improve from an ADEM attack. But a word to the wise is that people who have ADEM or children who experience ADEM often have very severe disability, but it's important not to give up, because with appropriate therapy and supportive treatment and with time, many people affected actually make a very good recovery. Diagnosis of ADEM is made by brain and spinal cord MRI. It's important to conduct blood tests, including the MOG antibody, and blood tests to rule out other causes such as infection. A spinal tap is performed to check for inflammation, infections, as well as the oligoclonal bands. We want to rule out a direct infection of the central nervous system in ADEM. If there's any evidence of a direct infection, then the patient would also be treated with antibiotics or antiviral therapies. There is no single specific diagnostic test or biomarker for ADEM. It's usually a monophasic disease, so a single attack, but in rare cases it can be recurrent. So this MRI just shows you an image from a person with ADEM. So often people affected with ADEM have many large fluffy lesions, or these white spots you can see on both sides of the brain. And then when the dye is given, all of the lesions enhance. So they all take up the dye, meaning they all have been newly caused with the current episode. Treatment of ADEM involves admission to hospital. Patients are usually given high-dose IV steroids. They may also need plasma exchange and or IVIG. After these therapies, patients usually take several months of a daily oral steroid with a gradually decreasing dose. As I said, recovery can be slow, but 60 to 90% ultimately make a complete recovery. And the allied health team, including physical therapy, occupational therapy, nursing, and other services, are often involved and very important to the recovery process. Okay, we're on to the last disease, transverse myelitis. So this is a disease involving inflammation of the spinal cord. The figure here shows you an example of the spinal cord. We have 3 segments: the cervical segment, or the neck, thoracic, which is most of the body, and we have the lumbar section. We actually don't have much of the spinal cord in the lumbar section. It's mainly the nerve roots and the bones. So the spinal cord ends for most people on the L1 level, so right at the top of the lumbar section. So transverse myelitis occurs when there's interruption of signals that travel from the brain through the spinal cord to the rest of the body, the limbs, the trunk, the bladder, and the bowel. And it can be caused by either an infection or a primary inflammatory process. Sometimes the term is actually used more loosely to include nutritious and toxic causes of spinal cord damage, but strictly speaking, the cause should be infectious or inflammatory. It occurs in about 1 to 8 per million people each year. It is usually a single attack, but repeat attacks are possible. So we have some patients who have recurrent transverse myelitis, but that's quite rare. And sometimes transverse myelitis is the first attack of MS, NMOSD, or MOG antibody disease. So it's important when patients present with transverse myelitis to test for these other diseases. Symptoms include weakness, pain, abnormal sensations or sensory loss, impaired coordination, impaired walking, loss of bladder and bowel control, sexual dysfunction, muscle spasms, occasionally respiratory issues when the cervical part of the cord is affected. And some patients experience this tight band-like sensation around their chest, which is also called an MS hug. So a lot of people with MS get this because they've had transverse myelitis in the past, but it can happen in people with transverse myelitis without MS too. So here I'm just providing a list of different causes of transverse myelitis, including the autoimmune or inflammatory causes. We've talked about some of these already: MS, NMOSD, and MOGAD. The term idiopathic is used when the cause cannot be identified, and usually people with an idiopathic transverse myelitis only have a single attack. There are other autoimmune diseases that can also cause transverse myelitis and affect other parts of the body too, so lupus and sarcoidosis, for example. And then other more rare causes include other autoimmune diseases like Sjogren's syndrome. Infectious causes are listed here. They include enterovirus commonly, also hepatitis or liver infection, different herpes group viruses, including varicella, which is a virus that causes chickenpox and shingles, HIV, syphilis, Zika virus. So this isn't an exhaustive list, but these are some of the common infectious causes. So workup and treatment. Workup involves an MRI of the spinal cord, also often the brain, to see if other regions of the nervous system are affected. Blood tests for some of the antibodies we already mentioned, as well as for infections. Spinal fluid testing. And we usually perform MRI annually for several years afterwards to see if the disease is evolving and starting to affect other regions of the nervous system. Because as I mentioned before, sometimes transverse myelitis is the first attack of multiple sclerosis. For treatment, we'll use antiviral drugs or antibiotics if an infectious cause is identified. For autoimmune causes, we use high-dose steroids and/or plasma exchange. And again, physical and occupational therapy and rehab are very important to the recovery process. So I just wanted to briefly talk about research around these diseases. I'm leading this study called Canoptics, which is an observational study investigating NMOSD, MOGAD, and other rare demyelinating conditions across Canada. We have many centers already participating, which are highlighted by the red stars there, and we have Vancouver participating now as well. Sorry that the Vancouver star got left off. An observational study basically means that we're just observing patients to see what different factors determine diagnosis, the course of their disease, and also response to treatment. So we're not actually directing the treatment itself. But it's very important that we have participants in this research because these diseases are quite rare, and we want to have better information for people living with these conditions across Canada in the future. So if you're a person living with one of these conditions and you're not participating in Canoptics, you can ask your neurologist if you're at a participating site. There are also many resources available today online for people living with these conditions and for their family members and friends. So I already mentioned the MOG project. The website is provided there. This is the Patient Foundation representing people with MOGAD, and they also have information on their website about transverse myelitis and ADEM as well. For neuromyelitis optica, there's the Guthrie-Jackson Foundation in the United States, and in Canada and the US, there's also the Sumera Foundation. And here you have a list of some of the different organizations which are devoted to people living with these conditions. MS Canada, as mentioned at the outset, also has materials available on these diseases. And also can be a resource for you and help to connect you with other people living with these conditions. So there are patient guides that are available on these websites. There are some videos that are valuable educational materials. And also these foundations can be important resources for connecting you with a community. There are also many podcasts that have been developed going over different details of these conditions. And I just listed a few here. You can Google them if you're interested. This is one resource that was developed by the MOG project. It's a patient ID card for people living with MOGAD. So sometimes our patients tell us that they go into the emergency department with symptoms, but these diseases are rare and many emergency room doctors haven't heard about them before. So it can be quite helpful to carry a patient card like this that just explains some brief details of the disease, if you are having an attack, that steroids often work, and who your doctor is in order to have a point of contact. So lastly, I wanted to conclude, as I began, with some words from people living with these conditions, and I think they highlight important points that hopefully came across over the course of the talk. So as I said, knowledge is power. So it's very important, that we inform ourselves of details and all the research that has happened in these diseases, and that we also continue to probe. We've learned more and more about these conditions and also successful therapies in the last, I'd say, 10 to 20 years, and I expect there will be many more advances over the next decade. I wanted to emphasize that quick action is needed if you do have new symptoms or signs of an attack in order to achieve the best outcome. So it's really important, if you have symptoms that are persisting for more than a few hours, you connect with a healthcare professional. And the other message I want to leave you with is one of hope. So with good preventative care and our many new successful therapies, our patients are living very full lives. A lot of people do make very good recoveries even after an attack. So, here's one patient who talks about with preventative care, he was able to achieve his goals and travel in his retirement. In conclusion, we talked about how NMOSD, MOGAD, ADEM, and transverse myelitis are rare autoimmune diseases affecting the brain, spinal cord, and optic nerve. Early recognition and treatment of an attack is important to recovery. We talked about the diagnostic workup, including MRI, blood tests for different antibodies, and often spinal fluid testing. It's important to recognize that these diseases can mimic MS, and they must be distinguished from MS to choose the right approach for long-term treatment. Some of these conditions don't require long-term treatment, but long-term treatment is necessary for NMOSD and in some cases of MOGAD, and we do have the benefit of newer, more effective therapies. Other very important resources include your neurologist, allied healthcare team, foundations, and patient communities. So thanks so much for your attention, and now I think we have some time for questions, and thanks again to MS Canada for sponsoring this session.
Thank you, Dr. Rothstein, for your informative presentation. We do have a couple minutes for questions, so I'll jump right into it. Can MS become or develop into an allied disease?
It's a good question. It's challenging. So I would say MS itself cannot transition to one of these diseases, but sometimes these conditions are initially misdiagnosed as multiple sclerosis and vice versa. So that is sort of one of the challenges. So because some of the attack types like optic neuritis and transverse myelitis overlap, what can happen is that with the first attack, the doctor who evaluates the patient may not think about one of these conditions because they're rare. So they may assume it's multiple sclerosis, and then it only becomes clear over time with another attack that it is actually one of these other conditions like NMOSD. So I've seen patients where, the blood test, the antibody is only sent after the second attack, and when it returns positive, the correct diagnosis is made. But after the first attack, the person was misdiagnosed with multiple sclerosis.
That was one of the other questions. Because it's so similar, what is the percentage of misdiagnosis? But it seems like it could be a common thing, and then the blood test is taken, is what you're saying?
Yeah, it's relatively common, but we recently evaluated this in our Canadian cohort, and the results, were promising in the sense that the time to correct diagnosis has really, decreased substantially in recent years. The median time to correct diagnosis overall was 4 months, which isn't too bad, but we aim to do even better in the future. But yeah, generally in recent years, the diagnosis is being made more quickly. There's wider availability of the blood antibody tests, and there's also better recognition.
Awesome, thank you. And just one more question. In research conducted with allied condition, is there any progress with remyelination?
Yeah, so there have been some studies of remyelination dating back about 15 years. Most of the work has been performed in the multiple sclerosis space, but potentially, because these are all demyelinating conditions, positive results in multiple sclerosis could translate over to the other allied health conditions. So there's one drug called clemistine that was shown to have some success in a smaller trial in people with multiple sclerosis. It's an antihistamine drug, but it also causes significant side effects like fatigue. So on balance, it doesn't seem to improve people's lives when taken on a daily basis. But it essentially, shows that remyelination can be possible, and other drugs are being studied now for their remyelination potential. Metformin, which is a drug that's already approved for treatment of diabetes, was found in animal models to have some remyelinating potential, and now it's in clinical trials for multiple sclerosis. So we're hopeful with further research over time, we will find additional drugs that may aid remyelination, and potentially these drugs could be taken as add-on therapies with kind of the current immunosuppressive treatment a person is taking to prevent future attacks.
Thank you so much, Dr. Rotstein. So we've come to the end of our time for questions. As we wrap up today's broadcast, we want to remind you about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. Connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time and can provide assistance in both English and French. We want you to be a part of the MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. To find out how you can take action, check out our website at mscanada.ca. If you have questions about any of our education activities, please reach out to the education team by email to education@mscanada.ca. On behalf of MS Canada, thank you for tuning in for today's webinar. Bye.